My name is Ruben Azokar. I'm the moderator. I'll be also giving a couple of the lectures today. We're missing one of our speakers. I'll get to that when we get to that. But thank you for being here, and thank you for those that are repeat offenders because they invited us again, and they also make for second year this of the ASA Center for Perioperative Medicine lectures. So you'll have access through that online to the contents. So I want to start with sort of an introduction to set the stage and why we should consider prehabilitation. My disclosures, I used to have none, and the last year I got like 5. That may be a sign of me getting older. So now I have a Nervio and an advisory board and I stock options on that company, and then Altura Health, Angel Devices, Boston Medical Data, and Your Best Anesthesia. I'm on the advisory board. So what I'll try to achieve today with you is review the impact of the growing geriatric population on healthcare, discuss the drivers of those outcomes in the older adult, and review the data surrounding frailty, and then give you the introduction to prehabilitation. So this slide I've shown before how there's an impact of a geriatric tsunami coming at us. And you can see when I start having an interest in geriatric anesthesia around 2010, the geriatric population was only 13% of the population, and now, as we are in 2025, it's close to 17 to 18%, and it's going to plateau by these statistics at around 20%. For me, it's also important. It's not only when you define geriatrics are those over 65, but one of the fastest growing segments of our population right now are those over 85, what we used to call the old or the greater old. And what's happening is that despite the fact that this population is only 17%, they take off at 38 to 40% of all surgeries in the country are applied in this population. And, just to take a glance of what that entails on the young old, they basically this amount of surgical DRGs is 34.1%, and the 75 to 84, the old, 25.9%, and the old 15.8%. So there is a significant amount, again, of utilization of surgical access and surgical cases on this patient population. Now, just as a reminder, we're the most expensive healthcare country in the world, at least compared with other countries that are on the G7 country. And when you look at the statistics, we really not do that bad until our patient population hits 55 to 60 years of age. So there is a significant cost that happens on this elder population that, again, keeps on growing. And, this is an old clip from USA Today that about 15% of the seniors spend half of the Medicare spending. Now, so we have this growing patient population. We're spending a lot of money on that, and you'll expect that the outcomes will be great. And the reality is that the outcomes are not that great. And I remember when this patient came, in the early 2000s, about how better we were doing in anesthesia, that our death per million had really significantly decreased, starting in the probably 80s and 90s with better monitoring and so forth. But as soon as you hit 60 to 65, the mortality increases. And the literature from our surgical colleagues is not that different. So if you look in blue on mortality and morbidity or complications, as you get older, complications go higher, and so does mortality. Now, why would you have a difference and say, well, I like to classify in 4 things. So there's age, there's coexisting disease, there's a type of surgery, and there's functional status. And I'm going to concentrate on the later, because age by itself will bring physiological changes, but not explain, the whole amount of complications or poor outcomes that we might have. Coexisting disease will also explain some of that, but we can maybe control some of those factors and make a difference. The type of surgery, we might have less control, but as a matter of fact, I think the surgical progress is helping us in that regard, because I can remember, doing open AAAs in 60, 70 years old, and the outcomes were, the whole surgery and peri-op was completely different from nowadays. But let's concentrate on functional status. And I think the key there is that chronological age don't necessarily correlate with functional age. And, I don't know, I'm a big Rolling Stone fan, and, you can see Mick Jagger. I worry when I see in concert that he's going to fall and break his hip, but he's, probably fitter than I am, while singing and dancing on the stage. And a little bit of that, and this is from an old anesthesiology, anesthesia and analgesia paper for Dr. Rook at University of Washington, is that, a basal state and in health, there is some decline of our organ function. Again, on health, right? So you have coexisting disease, this score might be different. What really happens is that as we get older, our ability to respond to stress starts decreasing significantly. We're probably at our peak around 20 to 30 years of age, but then as we get older, and even though our basal capacity might not have decreased as much if we're healthy, our ability to respond to stress feels that. And a little bit of that is when the concept of frailty starts coming along. And there are many definitions of frailty, but as I like things to be simple, I like to call frailty is simply the ability or losing the ability to rebound when you have a stress. And there is literature from the early 2000s, this paper from Hopkins, where you were looking at frailty as a prediction of surgical outcomes. And if you were intermediately frail, you had 2 more times chances of having a complication. Your length of stay was about 1.5 days longer. And this is, for me, is important because quality of life also matters, that there was 3 times more chance that you'll go to a nurse-skilled facility instead of returning home. But if you were frail, those were even higher, 2.5 for complications with 1.7 for longer length of stay, and like 20 times more likely that you will not go home after your operation. A most recent paper from the VA, they look at patients undergoing surgery, and they classify the surgeries in a high risk and lower risk and intermediate risk. And basically what they found on this paper of about 433,000 patients, mostly male because it's a VA paper, that about 8.5% of those were frail and 2.1% of those were very frail. And then in the frail, on the cases that were low stress surgical was 1.5% mortality. It was, if the stress was higher, it started reaching to about 5%. And those, as a reminder, exceed kind of the guideline that, you don't want to have more than 1% mortality. And then 30-day on the very frail, these, still have a significant amount of more mortality in both the low physiological stress and moderate stress on surgery. So they basically conclude what we know, that, frailty is a good predictor of bad outcomes and that we should apply frailty screening. Now, you might remember from other lectures or other speakers you might hear is that about 4 or 5 years ago, Stacy Diner, now in Dartmouth, published a paper around the time the ASA published also the frailty toolkit, and there's a majority of us would not do frailty assessment in our patients on the pre-op clinic. Now, this talk is not about frailty, but about prehabilitation. And this term has been around now for a while. And this year, or last year, there was this definition that you could read, but basically, it's this diagnosis when somebody needs to have surgery, what interventions of exercise, nutrition, psychological, respiratory training that aims to enhance the functional capacity and physiological reserve that the patient have to tolerate the stress of surgery. So I also like things simple, and I say, if I were to run a marathon, right, I don't just run the marathon. I train for a few months, get better nutrition, maybe get some, mindfulness so that I can run the 26 miles and get ready for it. And this is, Joanne Benoit, which I really admire because she was American, won the Boston Marathon 76 and run it, 40 years later. And she probably could run it twice and be running faster than me when I used to run. So why, if we train for a race, why don't we train for surgery that is a significant physiological stress? And basically, the why of prehabilitation comes on this. So if there's somebody that's a healthy older patient, they're coming and they have surgery, and then they might get sick and they might go into this critical zone, so they might need to go to the ICU or they step down, but then they recover, but they don't get back to the baseline. right? If you have somebody that is even frail or sicker, then they're declining, they have the event, and they might not ever, survive the event. But if you take these patients and give them some prehabilitation, and now their physiological state is at a higher level, that might be having a better outcome. So that's kind of the overall concept that was brought around 2017. And we're going to today concentrate on three aspects of prehabilitation. So one is the aspect of exercise, and I'll have Frankie Joyce from Tufts University. We'll take the space of Dr. Wismayer for Duke, who couldn't be here with us today, nutrition, and that's what's going to follow. And we're going to also talk about cognition, and Dr. Humiran for the Ohio State University. So my disclosures are the same, so I didn't repeat them. So what's the surgical rationale? Well, surgery is a catabolic event. So it's basically controlled trauma. You're going to open your belly, your hip, your chest, and then your body's going to react, and that has to be wound healing, and that all consumes energy and resources that you have. Now, we have there's a theory, or there's a high prevalence of low body weight and protein energy malnutrition in our patients, and it's well known that hypoalbuminemia will create postoperative complications. And the rationale behind providing some nutrition is that if you do that, homeostasis and muscle mass will get better faster, support inflammatory and healing process, and might decrease post-op mortality. And this is a graph from Dr. Wismayer and an article in AAA, I believe. And they say, well, only 1 of 5 hospitals in the country have a nutrition screening process. If you were a surgical resident or were during your surgical rotations or you hang on the ICU, the surgeons will always talk about nutrition. And also we know that the significant savings on providing better nutrition because there are less complications, but only 1 of 5 patients receive perioperative nutrition support. And 2 out of 3 patients pre-op might be malnourished at the time of surgery, 1% for GI surgery, and the mortality and complications are much higher. So what can you do about it? And this is also from the Duke group, published in AA as well. And if they have a very simple pre-operative assessment. So if you look at your BMI, if your BMI is less than 18.5, then if you had an unplanned weight loss more than 10% in the past 6 months, and 3, if you have been eating less than your normal diet for whatever reason on the preceding weeks, that will trigger that they get an albumin level, and if the albumin is less than 3, they will send you for pre-op nutritional counseling. And there are some principles that they follow, that it's, pre-op nutrition is essential. Protein is more important than calories, and that's important because, in the case of a private institution, where Frankie is now, instead of, giving, say, Ensure, we were giving like high branch amino acids, because they theoretically not only have immune, but were high protein content. Stop feeding pre-op late, restart early post-op. Oral nutrition is always better, and nutrition is a team game. So you have to, at any change management you might have, and prehabilitation might be one of the things that you might need to try to do as a change program. You need to involve your surgeons and your pre-op clinic and your nurses and everybody else. It's not only about us suggesting, the nutrition peri-op, but having everybody that is going to touch that patient in the same page. So we're going to be taking questions at the end, and I will invite then Dr. Joyce to do the exercise piece.
Okay, perfect. Great. Thank you all so much. And you'll see a little bit of intended, I have a background in education, and one of the things that is common practice is kind of repetitive exposure, and Ruben and I collaborate a lot, so you'll see some concepts covered that Ruben went over, I as well. So again, the CPEM, which we're really honored about. So my job has been to discuss exercise as one of the components for prehabilitation in preparation for surgery. And my objective is to tell you about some of the interventions that you can do and can be prescribed as part of a prehabilitation program, and then also some of the outcomes and what do the outcomes show. And I'm going to follow along with the marathon analogy and use my own images and my own preparation, but I'm going to carry it a little further. So for any of you that run races or run long distances or do any type of athletic endeavors, you know you would never step into an athletic endeavor without some preparation. So this is a picture of me at the Newport Marathon last year. I am currently in the process of training for the Newburyport Marathon in a couple weeks. So if you see me running along the river walk, come join me. So just like for surgery, you would put the effort in to get ready for your marathon, and at the same time, kind of taking this a little further, my issue this year has been I've developed patellofemoral syndrome. I've been a lifelong runner and never had any issues with running, and suddenly my knees really hurt. And I have taken on the benefit of doing physical therapy in order to get me stronger and get me better so I can get to marathon day with success, hopefully. And I'm going to take that to expand and compare it to frailty, just like the concept of frailty and that kind of decreased ability to handle that stress of surgery, my decreased ability to handle the extended miles as I go through, I would say is akin to frailty in some way. And we know that frailty is this phenotype. We know that is just expanded vulnerability. And we know that not everything is just age-based in terms of a reduction in ability to handle stress and stress of surgery, especially is what we're talking about, but it's often due to other factors. And there's clear associations, as Dr. Azikar already went over, including as related to mortality. And as Dr. Azikar also emphasized, there's importance in assessing frailty, and this is one of the many mechanisms out of Canada in terms of that frailty assessment. So what's the role of prehabilitation? And we've already touched on this a little bit, but my job's to convince you that not only nutrition, not only physical fitness, so exercise of your body, but also exercise of your mind, which Dr. Humadin is going to talk to you about, and then smoking cessation, glycemic control, and other aspects that we aren't necessarily going to touch on, but are certainly there to help and benefit patients as they go through. So we know that exercise-based prehabilitation programs, the goal is to get people moving and improve their overall functional status before they get into an operating room. Because if patients go into an operating room with more ability to move and tolerate, their decrease and their decline in functional status is going to be improved. The various types of programs include aerobic exercise, so going for a walk, a jog, things like that, resistance training, flexibility training, practice with balance, practice with strength training, so lifting, not necessarily going to the gym to lift weights, but even just minor 1 or 2 pound weights as you would do in a physical therapist's office. And then one of the most important parts and one of the things that's really focused upon in much of the exercise research is inspiratory muscle training, because one of the primary outcomes that we look at as anesthesiologists is postoperative pulmonary complications. So there are lots and lots of trials. They're really heterogeneous, and we'll talk about why that's probably a bad thing. But consistently, over and over again, exercise is shown consistently to improve your outcomes, whether it's solo or as part of another prehabilitation program. So in order to help someone improve, you first need to assess it. In a general sense, you can get a sense of a person's abilities to complete their activities of daily living or their independent activities of daily living and how they're able to go through. Even more so, you can go through and assess functional status. And essentially, if you have any one of these, whether that's age greater than 70, a diagnosis of frailty based on one of the myriads of definitions available, poorly controlled chronic illness, preoperative exposure to chemotherapy or radiation therapy, or as the World Health Organization defines, less than 150 minutes of moderate exercise or less than 75 minutes of vigorous exercise per week, you technically should go through some type of prehabilitation process prior to going in, and that's just a kind of a Gestalt assessment. You can do additional assessments, whether that be gait speed. There is good data. There was a study in 15,000 cardiac surgical patients over the age of 60 that looked and showed that gait speed was an independent predictor of adverse outcomes, and that there was increased mortality associated with slowing of gait speed. So it can be a really strong indicator of how that patient might do postoperatively. Time to sit and stand with chair repetitions, hand strength. You can measure some muscle circumference by ultrasound, the 6-minute walking test, and then, of course, the cardiopulmonary exercise testing, which is the holy grail of exercise testing, but is incredibly time and resource dependent. So what do the outcomes show? So I'm going to talk about it in a couple different buckets, and we'll start off by talking about major abdominal surgery. And when you look at major abdominal surgery, you see that if you introduce something like aerobic exercise or inspiratory muscle training or resistance training, that you're going to improve and reduce your postoperative pulmonary complications and overall postoperative morbidity. In 2024, there was a used component network meta-analysis that looked, and it showed that overall physical prehabilitation reduced the morbidity rate, the pneumonia occurrence, and the length of stay as compared to just regular routine preoperative care. When you look a little deeper, and this is, it was originally in 2017 that looked at 5 RCTs, and then in 2024 they added an additional 5 for a total of 10 RCTs. What you see here, and you can see as you go down, you see the top line is the exercise training, and then as you go down, the outcomes. And what you can see is that the exercise intervention is the most predominant in all of the various prehabilitation programs, and that it most consistently contributes to positive results from a length of stay perspective, a functional capacity perspective, and a postoperative complication perspective. In thoracic surgery, I think one of the important takeaways is we think very intentionally about patients with poor functional status, but I think one of the things to take away is that even if a patient has a good functional status going into surgery, you should really consider recommending or at least increasing their physical kind of exercise or some type of routine that is patient-specific, because even fit patients that undergo a prehabilitation program will show an improvement in their overall functional status postoperatively. The results are a lot more robust in patients that are unfit. However, in both instances, you see an improvement in functional status postoperatively. So this was a Cochrane review from 2022 that looked at 10 RCTs. And overall, again, kind of consistently, as was in abdominal surgery, you see that reduced length of stay, you see that reduced risk of developing postoperative pulmonary complications, and that increased ability to have a better functional status as you leave the operating room. Cardiovascular surgery, it's certainly not a new concept, and it's been done since the early 2000s. And when they surveyed the various types of prehabilitation programs, 3 of the cornerstones related to cardiac prehabilitation were inspiratory muscle training, strength training, and aerobic exercise. Those 3 components were the components that were most often included and then most often impactful. Of note, when they did look through and when they surveyed patients, one of the factors that they really thought about intentionally was that patients have a lot of apprehension about engaging in physical activity prior to elective cardiac surgery, which is understandable and something that clearly needs to be coached for patients as they go into something like an elective cardiac procedure. So as I said, early 2000s, again, in elective cabbages, there was a shorter length of stay in the ICU and better outcomes in terms of reported quality of life. That has since been repeated, and as recently of 2023, again, patients who have that improved functional capacity going into surgery will show an improved functional capacity after surgery, and you'll be able to reduce length of stay in addition to outcomes such as postoperative atrial fibrillation, et cetera. McIsaac and his group up in Canada published in 2025 a meta-analysis of 186 RCTs that looked at 15,684 patients. And what they found was that compared to usual care, postoperative complications were likely to be reduced with isolated exercise with a significant odds ratio. And what I like about this is they did a heat plot where they showed the various interventions and what the impact of those interventions were. And the green colors are the most impactful versus the red, which are least impactful. And what you can see is when you look at the exercise related or the ones that are related to exercise, you have the most impact in terms of improving patient outcomes post-operatively. So now that I've told you all the benefits, I'm going to tell you some of the shortcomings of all those studies and why we need to be really cautious in our interpretation. And McIsaac and his group from Canada did a really nice job in saying that, yes, we see these signs that most likely it improves all of these outcomes. However, all of the data is really low quality in that the studies just aren't powered strongly enough in order to be able to give us legitimate decisions based upon the things that we're looking at. So part of it is the heterogeneity with which these studies are performed, the heterogeneity of the populations, the intervention types, the outcomes that are looked at. You have various interventions. Some programs will do nutrition plus exercise. Some programs will do nutrition plus exercise plus glycemic control. Some will just do one of the interventions. So it's really, really important to try to be more homogeneous in terms of the intervention to then be able to tell which intervention is actually showing our positive outcome. Patient compliance continues to be an issue. So you might have this brilliant prehabilitation program, but if patients aren't completing or participating in it, it's not going to be useful. And you need to kind of be realistic in what you're expecting your patients to do. So you can put a pedometer on them and ask them just to increase their steps by 100, but if you put a pedometer on them and ask them to increase their steps by 10,000, you're not going to be very effective. So being patient-centric in addition to being reasonable with your expectation, because some movement is better than no movement, and a little bit of expectation management. So we'll take questions at the end again, and I have the pleasure of handing it over to Dr. Houmadin.
All right. Well, thank you everyone for coming to hear us talk about prehab. I'm going to be focusing on, let me see here, brain exercise. And what you saw in some of the diagrams earlier was that there's multi-components that contribute to prehabilitation, the exercise nutrition piece, and then there's this cognition piece that gets talked about. And in a lot of the studies, all of the studies, for the most part, that study prehab, when they talk about cognition, they're talking about mindfulness, anxiety reduction techniques, those types of things. They're not talking about active training of cognition for the brain, which I think is fascinating and something I've been studying for about 10 years now. And hopefully we'll show you a little bit about what we know, some things about what we hope to figure out over the next several years in trials that are underway, and some practical things that you can maybe encourage your patients to do at home. So cognitive reserve it's a really important predictor of cognitive outcomes after surgery. So we pretty much know that if a patient comes into surgery with some sort of deficit in their cognition, that their risk of having delirium afterwards goes up significantly. And I talk mostly about delirium because that is the most common complication after surgery in older patients. It's incredibly prevalent, and the link between that and cognitive reserve is very strong. And then, like I said, we'll talk about some therapeutic potential of actual brain exercises, not just the physical exercises. So cognitive reserve is a property of the brain that allows it to have a better than expected performance or response after some sort of a challenge or some sort of insult. And so if you can think back to your own experience taking care of older patients, you might remember, as I can easily remember, some older folks that come in and they're super sharp and they go through surgery and they're fine. And then you have other patients come in that also might be super sharp or not, and they go through surgery and they're not fine. So what is that protective factor that is there that's allowing some patients to recover well and some patients to not recover well, to have delirium after surgery? So these large review studies kind of really hone in on what the risk is when you have low cognitive reserve. They're looking at non-cardiac and also cardiac surgery patient cohorts. And like I said, it's pretty clear that when patients come into the OR with cognitive impairment and they're older, they have an increased risk of delirium. They have an increased risk of discharge to some other facility besides home after their surgery. Their readmission rate goes up, and even their mortality, okay? And we spend mega money on delirium in the United States after surgery as well. So this is a very important relationship between pre-existing cognitive issues and the postoperative outcomes. Similar relationships are seen in cardiac surgery patients, with the delirium risk going up very significantly, and also length of stay and time in the ICU afterwards. So cognitive reserve kind of falls into that predisposing factor category of different things that contribute to patient risk with regards to delirium and cognitive recovery after surgery. One of the things that's really challenging about cognitive reserve is it's multifactorial. It's something that we develop over the course of our entire lifetime, but it's also modifiable. So lots of these different things that contribute to cognitive reserve become acutely important in the perioperative space. Things like their overall health status, how well they're sleeping, their nutritional status, like we talked about. Substance abuse is on there, but you can think of that more as polypharmacy in older patients. So a lot of these things that contribute to the way our brain has a reserve or lack thereof are happening in the perioperative space. And that makes it very difficult to measure. So we have a variety of screening tests that we do or are supposed to do before surgery. As Dr. Azikar mentioned, our compliance with that's probably about 10%. We should be screening all older patients based on best practices for cognitive deficits at baseline before the operating room, just to help with this risk discussion, just to help this, with their goals of care discussion. But we're really not doing that. So our screening tests, though they're available, we don't use them. And I'm not convinced, based on some of my research, that they're really picking up on all of the clinically significant risk that might be present. So if you look at this study by Toe and colleagues, which is just about 10 years old now, this is a fascinating relationship and observational study where they queried patients about their cognitively stimulating activities that they do at home. And then they also did some literacy testing. Literacy is considered to be kind of an early life cognitive factor or, characteristic, and the daily activities, the daily stimulating activities, was more of a measure of late life reserve, things that are relevant kind of in the present day. And what you can see here is that, particularly with the leisure activities up here on the top there, that the more a patient did, the lower their delirium risk after surgery was. And each activity, they looked at 12 in total, each one that a patient did consistently lowered their delirium risk by about 8%. So what kind of things were they looking at? Really simple things like reading the newspaper, reading books, knitting, playing cards, social interactions. That's a really important part of what we can do to encourage good cognition in our patients is social interactions. So these really simple things, the more that these older patients did them, the more likely they were to recover after surgery without delirium. Kind of building on that, when you're, from a scientist standpoint, when you're looking at cognitive reserve, you want to start thinking about things that we can say prove the reserve is there or not there. So how does cognitive exercise actually work? What are we modifying? Those types of questions. And I really like this study, which was a post-analysis of the SAGES, which is the Successful Aging After Surgery study. And what they looked at was a marker of inflammation, and they looked at basically vocabulary fluency. And so that firm line, that firm black line up there on the top left, that shows kind of the relationship between vocabulary and CRP, which was the inflammatory state. It's a kind of distinct line there, meaning that in those patients that had lower vocabulary scores, they were at the same risk of delirium kind of no matter where their inflammatory state was. But if you look at the bottom line that says high WTR, that's their fluency, their verbal fluency, that especially at lower inflammatory states, it was protective against delirium. And that relationship kind of persisted up until you got into the really high levels of inflammation where it was just kind of too overwhelming for any reserve to actually have an impact. So I think that there is some good basis to study cognitive exercise because we know an active mind is protected, and we are starting to see that there might be physical relationships, physical modifiers that we can see when we have a lot of cognitive reserve. So let's talk about the therapeutic potential of brain exercise. I'm going to tell you about the Neurobics trial. This is a trial that enrolled from 2015 to 2019 at Ohio State. It was a single center trial that I ran there. And we were looking at testing cognitive exercise compared to no intervention. So basically sending the patients home and telling them to do what they normally do at baseline. And the impact of that brain exercise on delirium. And these were non-cardiac, non-neurological surgery patients age 60 and older. They needed to be having major surgery, meaning that we expected them to be in the hospital for at least a few days, 3 days after surgery or longer. And they had some important exclusion. The most important one is that we eliminated any patients that had pre-existing cognitive deficits. So a lot of the cool research from Deb Culley and other folks that have informed us now about how many of our patients are showing up to clinic with baseline deficits, which is about 1 in 4 to 1 in 5, depending on which study you look at, which is a lot. I, during this trial, didn't realize that that was a thing, and those people just got excluded. I viewed that as more of a confounder. So hopefully I will be repeating this work in that really high-risk patient population in the next couple years. But nonetheless, that limitation aside, these were very educated patients. They had an average of about 15 years of schooling. That's just the way that it worked out. And they were normal on the mini mental status exam. And they had no other reason to think that they had cognitive deficits at baseline. We gave them a battery of tests, or games rather, on an iPad. And it doesn't require the internet to work. So they could take this home, no matter what their setting was at home, and use the iPad that was provided by the researchers. And we asked them to play games that spanned these different cognitive domains for an hour a day for at least 10 days. So we tried to capture them a few weeks before their surgery and get them to a preoperative dose of about 10 hours of gaming, which is a lot, okay? But we'll come back to how they did here in just a second. But this is some visuals of what the games look like. If you've ever played Lumosity, it's really kind of fun. You know, they let me use their software for free. I have no other relationship with them. But we, gave the patients the game, and what they did was they could go into this battery here on the right, or this library of games, and they could pick and choose. So that's another limitation of this trial, was that we didn't give them a specific sequence of games, which I think probably helped with compliance because they got to pick and choose what they liked, but it did limit our ability to look at things like how they improved in that gaming score over time. Again, things to think about for my next trial. So the neurobics trial ended up with 268 patients. They were 60 years of age and older, a median age of 60. We had them randomized to either control or intervention. The median gameplay time was 4.6 hours, so about half what I asked them to do, but it was really variable. The interquartile range was somewhere around 2 hours up to about 8 hours, okay? So in the control group, the delirium rate was 23%. And in an all-comers intention to treat analysis, the delirium rate in the intervention group was 14.4%. And we used the CAM and the Memorial Delirium Assessment Scale to diagnose that also with chart review. What's interesting is if you take out the 4 patients that didn't play any brain games, then our delirium rate goes down to 13%. So if you just look at the patients that actually did the intervention, our delirium rate was 13% or so and 23% in our control group. Another interesting thing about this was dose seemed to be important. Like I said, we only got about half of what we had wanted from the patients, but that might be all we need is 5 hours. If you break it down here, you can see that the patients that played less than 5 hours, their delirium rate was about 18%. If they got in the 5 to 10 hour range, it went down to 10% and then really stayed right around there. Not a ton of additional benefit for getting up over 10 hours. So again, things to think about for the future of this research is the dose effect. So a few years have gone by since the neurobics trial. I was very excited to see this trial come out that basically made me feel like I was, on the right path. This trial was in cardiac surgery patients. They also had a computer-based brain exercise intervention. They got a median gameplay time of 6 hours, so a little bit more than we did. And a lot of this was based on the neurobics trial, their protocol. And they did include cognitively, patients that had some deficits at baseline, not just totally cognitively normal patients. And what you can see here is that their delirium rate in the routine care group was 40%, 43%, which is standard for cardiac surgery. It's higher than other types of surgeries. It went down to 27.5% in the patients that got these brain games. So there's some more trials that are coming that I want to mention just so you can keep an eye out for them. This is one I'm watching. It's called the NCORE study. They're actively recruiting right now. This is a pen and paper based cognitive exercise intervention. So I'm really curious to see how this goes. And I put Where's Waldo up there because when I'm looking at the different things that they're doing, it's really kind of fun. They have a Where's Waldo, paper-based thing and lots of other things. They're asking for 40 minutes, 6 days a week for a few weeks before surgery. Another one that's coming that's actively recruiting right now is my current trial at Ohio State with these other institutions, also in cardiac surgery. It's called the SCOPE trial. We're doing a repeat of the neurobics intervention, but also layering on sleep interventions and some pain control after surgery interventions as well. So you can stay tuned for that. It'll be hopefully it'll be about 3 or 4 more years before we have this trial completed. This just is a schematic of that. Like I said, we're again repeating the Lumosity and then some other sleep and pain-based interventions for that. Another one I want to mention that's ongoing is looking at that dose effect, and this is actively enrolling. There's nothing to share at this point, but they have a group that has no brain exercise, a 5 hour, and then a 10 hour, also in cardiac surgery. So if you Google this or you're looking online, you might see a few of these meta-analyses that have come out, and I just want to, kind of encourage you to be a little bit skeptical when you read these because there's not that much research in this space. And when they pull them all together, I think that the conclusions can be a little misleading. Some of the brain exercises before and after, some just before, some just after surgery. So it's really hard to draw conclusions. I think if you just stick with the randomized trials and then kind of look out for these ones that are ongoing that we'll have results from in the next few years, I think that'll be more informative than these meta-analyses that are focused on just a really small amount of trials that are really heterogeneous. Just a couple of words about the future here. This is an area of active, investigation. Compliance is important. dose is important, and looking for ways to discuss the mechanism of how this might be working are also important, as I'd already mentioned. So a couple practical things that you can do. From a research standpoint, I think we're getting into the era where we can't have a control group that we tell go home and just do what you normally do. I think we're at the place now where we are obligated to tell them and share some of these patient infographics that you can find on the ASA Peri-Op Brain Health website to stimulate your mind, be social, do activities at home that can be stimulating, get your sleep, get your exercise, those types of things. The Help Elder Life program has been shown to be very effective after surgery and helping with delirium. And like I said, the Brain Health Initiative is a great resource through the ASA where you can find these types of infographics. And also the APSF has a lot of great information about this as well. So I think we should encourage our patients to kind of do the basics, and then we'll evolve over time with maybe more, different types of interventions depending on how things go. This is another infographic from the ASA. Again, it's talking about, do things to keep your mind active, get your sleep, engage with your friends and your family. These types of things I think are very important for brain health as well, and kind of more practical to do than some of these study-based interventions right now. That's everything I wanted to share today. I have not missed a Rolling Stones tour since 1989, from the first time I saw them, and I took my daughter last year in Cleveland. And if you love geriatrics, that is a good place to go. So thank you.
All right. Well, thank you for having me. I am a late substitute. So apparently we're missing 2 out of your 4 or 5 speakers. So we might think about prehab prior to ASA for your next round of speakers. But I'm Chris Hughes. I am giving a talk here for Kimberly Rangel, who's my mentee. Worked closely with for now almost a decade. And we're, I think, going to try to wrap this up with just a little bit about like how to pull this off and sort of maybe like how to actually perform some of these exercises. Oh wait, that's right. The keyboard's not working on these. Disclosures, we do have some grant funding. One of the trials I'm going to talk about is that first NIH trial, which will be one of the coming soon trials, but a fair amount of NIH grants. And then I have a steering committee work, but as for outside of this, it's for my ICU sedation research. And then, of course, the ASA Center for Perioperative Medicine slide. So I've seen a bunch of different ways of looking at this from the different talks so far. But this is, identifying FRIT, pre-fail, and frail patients because they actually make a difference on how the outcomes go. And we've heard reserve, we've heard this is showing resiliency. How are you going to handle that insult compared to patients who don't have that, right? So that somehow I've got a random dot that's going on there. That's not me. My hands are up here, right? Yeah, okay. All right, that's weird. We have a ghost. Okay. So the point of this, though, I like this slide because it shows you that how your patient shows up really does matter. We all know, there's surgeons that have good hands or bad hands, right? We have hospital systems that have good systems in place, and those that don't have good systems in place. And here's that dot again. Whoa, let's do this again. I'm going to start this up again. All right, no dots. We're good, hopefully. But it really, if you look at the complication rate, like the difference based on healthy versus frail is huge, right? So 1 to 5% versus 66 to 89%, right? So again, they actually looked at surgeon performance, hospital performance, and it's really the patient performance coming in that was by far the biggest driver in these that is back. Oh my goodness. This is weird. All right. So looking at the types of prehabilitation, we've heard about some of this, right? Aerobics or high interval intensity training. I think that's one that we'll talk about. the resistance training using some weights or some resistance band, and then nutrition and mindfulness is a big one. But as Michelle's highlighted, there's actually another angle here, which is actually active cognitive training, which we'll just touch on just a little bit at the very end. But the original trial sort of looked at this a couple times a week for about 3 to 6 weeks per surgery. But I think we all know that, time frame before surgery is limited. This is like on its own mind. I did not create this. All right. 3 to 6 weeks before surgery. But I do think we need to find better ways to do this in a shorter period of time, because I'm sure your place is just like mine, which is trying to get patients in and through as much as possible. But with this, these smaller studies improved functional status before surgery and fewer complications. The issue with some of this heterogeneity is it's all for different types of surgery. And each type of surgery has its own type of prehab, and each study within that type of surgery had a different way of doing the prehab, and there's not a great way to combine this. So I'm going to try to just share some highlights to get thinking about what would be maybe the prehab intervention. So this was showing from lung cancer surgery. This is high intensity interval training. That seems to be a theme that you'll catch when we see some of the ones that have been most successful. 8 sessions over 25 days or so. And they found increasing aerobic capacity, increasing power, and then increasing walk distance. So this was actually, I think, proof that you can change someone's functional capacity before surgery if you do the right exercise. And in this case, that was interval training. This is for hepatic surgery. This was a combined moderate aerobic and resistance exercise. They were doing the longer sessions, but also about 3 times per week. And they were also able to improve 6-minute walk distance. They were also able to improve sort of muscle mass versus fat ratio. And in this case, they actually found a shorter hospital length of stay as well in the prehab group. In major abdominal surgery in high-risk patients, this one is a little bit more of now the constellation. So this was a personalized exercise program. They also had a motivational interview. And then they had high intensity, but more on endurance instead of the interval training. And this also demonstrated increased aerobic capacity and had a decrease in postoperative complications. So it does seem, I don't know, Kimberly must have this set as like an auto advance or something, but it does seem that we can make improvements before surgery in several different types of surgery, but the types of exercises have been different, whether it's been interval training or endurance exercises or strength exercises. So this one, in addition, also showed that prehabilitation was protective against 30-day hospital readmissions, which I think is a really important number. If you're in any sort of hospital administration, this is a marker of quality, but it's also a big deal for your throughput and in keeping your hospital moving as much as possible. I like the fact, geez, oh, Pete's. I'm going to just hold my hands like this the whole time. I like the fact that this actually showed that they were able to sustain, though, their activity for up to 6 months after surgery, which I think that is actually one of the more important outcomes here, because if you can keep them launching, then they won't come back, or they won't get their complication, or they won't need their next surgery, et cetera. So this is a schematic of general surgery cases, 36 studies that were included in this systematic review. And what's really interesting here is you pretty much see it's like 50-50, right? So 50% showed, 45% showed improvement, 51% showed no difference. I don't think anyone's showing harm, so I think we can at least throw that away. So it's not going to hurt anybody to do this, but I think it really comes down to more about cost and resources. So you're wanting to see improvement so you can justify the cost, especially in today's environment. Nutrition actually did not show much benefit on its own. 60% of them showed no difference. And then the psychological one actually seemed to be the most positive in terms of the highest percentage of them showing improvement. When looking at postoperative complications in hospital stay for cancer specifically, this is, I think, one of the patient populations that you see most in these prehab, because those tend to be the ones that you have identifying and have elective surgery, if you want to think of it that way, but also are older, comorbid, frail, and would need this. So this is specifically looking at cancer surgery, and they kind of split into what type of cancer, like where was this cancer. So genital urinary, GI was split into lower or upper, and then lung cancer. And they did find some reduced postoperative some some reduced postoperative complication rates, but this was primarily driven by the lung resection cases. They also had decreased length of stay in that, but in the other types of cancer specifically, they did not find overall incidence of lower risk. But again, because of the heterogeneity, there's a lot of bias here. So it goes back to, again, identifying the right patient, the right dose, the right intervention. We're still trying to figure that out. But at least lung cancer seems to have it figured out better than everybody else so far. Maybe if I actually hold my hand on it, that will keep it from going. This is looking at high intensity interval training, so using that as your cardiorespiratory fitness, and seeing if that specific type of intervention would be good for a prehabilitation angle. And this was 12 studies that utilized this intervention, 8 of which were included in their analysis. Moderate quality evidence, so maybe a little bit stronger for this specific type of exercise. They did show improvement in the ability to exercise with VO2 peak max, and then also were able to find a reduction in complications, but it did not translate over into a length of stay. But again, as you can see in all of this, high heterogeneity outcomes, but they overall thought this, specifically for interval training, had low risk of bias. There's a couple programs that combine several things that I'm going to show you for these last bit of slides. So this is called the SPAR program, Surgical Prehabilitation and Readiness Program. And so this was a multidisciplinary one that looked at physical activity, respiratory fitness, nutritional optimization, and mindfulness, so throwing the kind of whole package together. This was a single institution study. It was so they had 118 participants in this, and then they compared it to NASQIP data from 4,000 patients. There's our thing again. If I move, maybe it's just like me moving my hands. It shows up. I don't know. Yeah. All right. Maybe not. The ghost of room 303A in prehab. So this was compared to NASQIP data and looking at what the predictive risk would be versus the observed incidence, and they found a lot lower observed incidence in this SPAR than was predicted by the NASQIP measures. As you can see by this random red line who is circling something from somewhere right there from the discharge to facility, and the 30-day readmission was also lower. In 20 years of doing this is the first time. This is interesting. I'm never going to offer to give Kimberly's talk ever again. So this is an interesting study that got a fair amount of press. And this was looking at multimodal prehab. And they called it the Prehab Randomized Clinical Trial. So good, catchy name, especially for people interested in rehabilitation. This was for colorectal surgery. Importantly, most of these patients had laparoscopic or robotic surgery, so kind of minimally invasive from that regard in short stays. Go backwards, sorry. 4-week in-hospital supervised multimodal program. I was just trying to figure out how we could pull that off. If they would let me put someone in the hospital for 4 weeks, supervise them to make sure they get better. But if you can pull that off, it should be its own trial of how to do that, and an own hour-long talk with or without the ghosts. Your patients will do better. So exercise, 1 hour of aerobic exercise. They also had strength exercise 3 times per week. They did the interval training on a bike. They had a dietitian. They had macronutrients. They had protein supplements. They made you stop smoking because you were in the hospital for 4 weeks. And they also did some coping mechanisms and some other things. And so pretty robust intervention. Now, you can question whether this is scalable, and I guess probably just did. But the results were really strong here. So in the prehab group, they were able to increase their 6-minute walking distance. They were able to increase their oxygen consumption, and they were actually also able to increase strength, both by chest press and by hand grip strength. Importantly, it translated over to reduced complications. So they had all complications, and then they broke it down into medical versus surgical and severity. There's the red thing again, showing the severe and the medical and the surgical and the both being highlighted, all of which were lower with this intensive prehabilitation. That's weird. It's like not even my eyes. I'm trying to figure out what is following this thing. So two slides here on okay, we've given you a lot of data on what we've, what the data have shown, trials have shown so far, and have made some, kind of innuendo and some comments on what we think is where this needs to go. But there's a couple statements that came out of this, and again, really trying to drill down on the populations that will be most likely to benefit, the composition of the programs themselves. Is it one? Is it multi-component? And then the dosing, timing. But also, I think, what are the outcomes that we're interested in? Is it the length of stay? Is it the complication? Is it a long-term? Is it readmission? Is it all of those things? Cost effectiveness, unfortunately, in this day and age, is a thing. So again, if putting somebody in for a hospital for 4 weeks may be great, but it may be hard to justify that cost and ability to do that. So these things need to be considered in these future trials. Dan McIsaac, myself, and a couple others were part of this 2025 ASA guidelines on older adults, and one of the sections we were supposed to comment on was prehabilitation. It was an issue that we wanted to talk about for older adults. We wanted to create a key question about it, but because when we did the systematic review, we couldn't find articles that were specific to older adults. So we had to pull it out of this and just make a recommendation statement instead of actually having a key question that was addressed by that, which I think tells you the quality of the evidence specifically for older adults and not just individual surgery types. And so the efficacy needs to still be proven for older adults specifically. Again, how to optimize the intervention so that they can do that intervention in older adults with frailty and sarcopenia especially. And then sort of the cognitive prehabilitation. Is it lumosity specifically? Is it, is the dose, as we talked about, some more different data there. So that's really where the future directions are. The really kind of the mechanisms and the individualization, but yet at the same time, how to make this scalable and equitable for everybody. And then I have a question about this in the sense of, is it just the prehab, or can you take that same system that in place if we do this, and why not take it to rehab? Like, take all those same interventions and keep doing it after the surgery. And that's what we're doing. So I was a little hurt that Michelle did not find my trial and put it up there, because we're pretty close to being done. Yeah, that's fine. Okay. I'm just giving you a hard time. And she was saving it for us. Oh, come on. All right. So this is our COPE iOS, so you have to have a good name for the trial. So cognitive and physical exercise to improve outcomes after surgery. So this is a novel pragmatic, it's remote, okay? So this is a remotely delivered comprehensive program, and we are doing both cognitive training and physical training exercise. So what this looks like is we take patients out of our high-risk clinic. So these are all older patients. So everyone's over 60, major surgery, non-cardiac, three days minimum hospital stay, all mostly open surgery, a lot of cancer. But we actually enroll them to either the COPE program or active control. The COPE program is a brain game computerized cognitive training that adapts with them. They play, it just gets harder and harder and harder the farther they go. And we ask them to do 30 minutes a day, each day, but really the goal is 5 days a week if they can. We also have a group exercise session that we do with them on Zoom. So you get a bunch of 60-plus-year-old people on Zoom. So that's the first challenge. And then we have and we do actually aerobic exercises with them, led by a physical therapist. We have a bunch of stuff we do at baseline, and we do that at the same time at 12 months. So that's looking at cognitive function, physical function, but we also have MRIs in a decent amount of these patients, and we have blood draws at several time points throughout this to look at mechanistic. And then really just my last slide is I do have permission to show these pictures. So this is our first patient that we enrolled in the COPE iOS trial. This is one of our colorectal surgeons with us. Here are two of our PT and OT folks that lead it. This was Richard Simmons Day, so we have a lot of fun with them. But you can see some of our older patients. Some are even almost like wheelchair, but we have them doing it from a chair. We have dogs, we have kids, we have all kinds of stuff that show up in the video, and ends up creating really like a bunch of team camaraderie, which I think ends up being part of this too. So we are supposed to enroll 250. We are over 300 at this point because a bunch of people end up when they're old and sick, get their surgery canceled. So we're 250 that are having surgery, and so we're at 247 as of yesterday. So pretty close. So hopefully next year, if we make it, enough people show up to present. So thank you for Kimberly, myself, our research group, the High Rise team, and a bunch of our scholarship. And sorry for the random dot ghost thing flying around in the presentation.
So we're a little over the time of the lecture. So if there's any questions, please come forward. Because thank you, Chris, Michelle, and Frankie, and thank you for attending the session. Thank you.